So Christine, as always, fantastic talk and privileged to highlight advances in mechanical support, and heart failure is the ultimate team sport. Here are my disclosures. And a group of us spent a lot of time putting forth this latest ASE guideline document. And in this, we go over, a contemporary review of the devices, the selection considerations, perioperative management, and then troubleshooting, both for echo and multimodal imaging. So I certainly refer you to this comprehensive document, a spinoff of our 2015 guideline. For today, I want to highlight some selected device types, define the role for echo after temporary and durable support, with some emphasis on what parameters and the assessment to know and report on, and highlight the evolving role of multimodality imaging to manage specifically patients on durable LVAD support. So the Impella temporary support, which is a microaxial flow device, pulls blood from the left ventricle, propels it above the aortic valve to increase perfusion to the body and unload the left ventricle. The CP certainly helps us, a femoral approach. The Impella 5.5 is a game changer. It lacks the pigtail, but it allows for more extended support placed by means of an axillary graft as depicted in panel B. Now, the right-sided devices on the Impella RP can be placed by either a right IJ or a femoral approach, microaxial flow. It takes blood from the cava or right atrial chamber and propels it above the pulmonic valve, really to offer robust RV support. The indication labels support extended up to 14 days. The Protect Duo, which is actually a cannula, can be coupled with a pump of your choice, centrifugal, either a Centromag or the tandem heart pump. What's nice about it is you can split in an oxygenator to provide RV and pulmonary support. Similar physiology in terms of with taking blood by a dual cannula lumen means and propelling it above the pulmonic valve. So the questions that come up are device position, the degree of unloading, dependency, readiness to wean, device-related complications or complications that occur, and you want to know if there's intracardiac, specifically clot. And so echo is first line in this regard. I think keeping it simple, for the CP, remember the goal distance is 3.5. For the 5.5, it's 5. And so blood comes in at the inlet at the inflow, and it's the echo dense right in the middle, as you can appreciate right here. So this is the measurement within this area to the aortic valve. For the CP, 3.5. For the 5.5, not towards the end, you can get mirror artifact, but right there to the annulus is best one can measure. And it may be forgivable with some deviation dependent upon the heart size. TE can be very useful as well early post-procedure, and if there's a challenging transthoracic echo, to understand this ideal position. So certainly reporting on this would be key. You can use either a POCUS or transthoracic to guide those devices that seem to be too far in and guide pulling back. The malposition most challenging in terms of repositioning is when it's in close proximity to the mitral valve apparatus and directed to the anterolateral wall as depicted here. It really mandates a torquing maneuver, and concomitant echo can be helpful to guide that replacement. TE for the right-sided devices is particularly helpful, in particular the RV inflow-outflow view. Here's an RP that had migrated below the pulmonic valve as evidenced by the continuous flow Doppler, and with repositioning by TE in a more workable RVAD configuration. I'm going to transition to the durable LVAD. HeartMate 3 is the only currently FDA-approved pump which draws blood from the left ventricle and via the outflow cannula, propels it into the ascending aorta, robust hemodynamic unloading. This device is novel in that it's full mag-lev, very large blood flow pathways to where hemocompatibility is the best we've seen, and importantly, this intrinsic pulsatility that is 30 times per minute, where the speed in an auto way goes up and down. This pump is significantly better, more forgiving than the older technology, as evidenced by freedom from disabling stroke and pump thrombosis. Here's the STS Intermax report, more recently in 2024, and you can see the significant improvement in survival, starting to bridge the gap compared to heart transplant. 5-year survival is 64%. And in particularly, when you look at young patients, a 5-year survival of 76%. That is heart transplant survival at 5 years in looking at all comers. But we're still concerned about infection in particular. It's reassuring stroke has been minimized, as well as GI bleeding. Device thrombosis is under 1% in patients reported by the HeartMate 3. Our reality is that 1 in 5 patients still have smoldering heart failure, and smoldering heart failure is associated with increased mortality. So one must go through the differential as defined here in terms of mitigation opportunities to optimize the heart failure burden. Understanding outflow, inflow, cannula issues, valvular regurgitation issues would be key. Again, for the HeartMate 3, pump malfunction is typically a non-issue. This inflow cannula should be directed ideally towards the anterior leaflet in parallel with the septum, associated with flow that's non-obstructive. And remember your Reynolds number, it should be under 2 meters per second, more typically under 1.5. And we highlight in the document that the HeartMate 3, with its pulsatility, you will see increases in the peak velocity, not to be mistaken for intermittent obstruction, and this can go as high as 1.2, maybe even 1.4 meters per second. The inflow cannula can be seen nicely in the peristernal long. You won't see it at the base if ideally positioned in the apex. You'll see a hint at the papillary mid-level, and then certainly you see the nice depiction here, free of interaction with the endocardium. What we're screening for, and it should be described, is the position where it's directed, and if there's any deemed association with the endocardium. So this is very anterior distal aneuryseptum associated with low flow alarms. So in addition to inflow malposition being associated with low flow alarms, suction events, and compromising heart failure, the common denominator for residual heart failure is the underlying elevated filling pressures. There have been 2 published reports looking at the accuracy of echo to predict a wedge greater than 15, traditional candidate variables consistent with the ASE guideline in estimating wedge in a heart failure patient. So we have a published report that dates back several years looking at the mitral valve EA, additional parameters in terms of RA pressure, LA volume index, and EE prime. This has been looked at by additional sites. I love nothing more than to see this E less than A, low pulmonary pressures, as opposed to seeing what would appears to be more restrictive physiology on an LVAD support. And so Simone and colleagues examined an algorithm, similar concepts, meticulous assessment to estimate right atrial pressure. What they showed not only is accuracy detecting partial LV unloading, but optimal hemodynamics defined by echo matter. And so those with estimated normal wedge, certainly better event-free survival compared to those who are not. So in the document, we highlight reporting on diastology in keeping with a standard echo that would be done for a heart failure non-LVAD patient. A few comments about MR and aortic regurgitation. It is reassuring that compared to pre-implant, significant MR, moderate or severe, seems to be less when those on the HeartMate 3 than the HeartMate 2, and it's sustainably less over time. And even if they do have significant MR, no implication with regards to event-free survival or overall survival. We feel this pump is robust, and we typically manage this medically in pump speed adjustments. With aortic regurgitation, similar concept in the HeartMate 3 compared to older technology, lower incidence of aortic regurgitation. This was proven in the CAP trial as well. And importantly, even for those that have aortic regurgitation, no compromise on event-free survival. Now, we still are challenged at times in some patients, so we use the conventional echo parameters, vena contracti, particularly like the jet width, LV outflow tract width, height. There are some novel parameters. When you have a regurgitant loop and high diastolic peak, the ratio compared to the systolic will be lower, and this can help in terms of understanding freedom from having to intervene. And there are some interesting considerations with what valve to choose in this patient population. Standard reporting recommendations related to LV size. Ultrasound contrast is your friend. Here, this patient had a suspected TIA. Turn on the lights, you see an aortic root clot that may otherwise be difficult to define. So we have and recommend standard templates, surveillance, troubleshooting, optimization, and recovery. Certainly won't go through all of those. We want to see this as those ordering the test on the report to put this in clinical context. And so with LVAD troubleshooting, there's a differential. CT, I won't go into a lot of details, very helpful in understanding the outflow cannula-related issues that can compromise morbidity. Early postoperatively, echoes first line for detecting significant RV failure, very small LV, dilated RV, and distinguishing that from tamponade, which can be difficult to distinguish. When we see significant effusions of low flow alarms, the goal is to drain it. And then late RV failure has evolved as a real issue in about 15 to 20% of the patients. Interventricular septum bowing over to the left, high right atrial pressures by echo. When you see that with the left atrial EA ratio less than 1, where the LV is unloaded but the RV struggling, this patient's best served by transplant or inotropes but have a poor prognosis. And so with regards to infection and the evolving role of multimodality imaging, FDG PET is a game changer. It helps us delineate central versus peripheral infection, and the implication is in terms of outcome, those with evidence of active infection at the pump site or the outflow cannula anastomosis site don't do as well long term. And so echo remains first line to manage this patient population, but CT in particular can be very helpful as a second line therapy to manage those on durable LVAD. So these temporary shock devices can provide extended LV and/or RV support in selected patients with shock. Those with end-stage heart failure, the HeartMate 3 is the most forgiving pump that we have. And as mentioned, echo is very useful. I focus in on device position, alarm troubleshooting, and device complication detection, but it's helpful on the front end and for long-term considerations related to myocardial recovery. And multimodality imaging, particularly CT, I think is here to stay, in particular related to infection screening. Always love being part of this meeting, and look forward to the question and answer aspect of this. Thank you.